Today, we'll be discussing benign prostatic hyperplasia, or BPH, and this presentation is geared towards medical students or clinicians who are seeking to review the pathophysiology and treatment of benign prostatic hyperplasia. And this is presented by me, Christopher Moran. I'm a third-year medical student, so let's get to it. All right, so benign prostatic hyperplasia, let's start with our definitions. Benign prostatic hyperplasia is benign proliferation of glandular and stromal tissue within the transitional zone of the prostate. That's the zone that we see kind of around the urethra, right? Benign prostatic syndrome is more of a clinical diagnosis, and those are the lower urinary tract symptoms that are caused by BPH, and this is what we treat clinically. Here we see a gross specimen of the prostate. This is a normal prostate, and what they did was, remember, the prostate is a walnut-sized glandular organ, and they cut it in half, right? They cut it this way. And in the center here, we see the urethra, and this is a normal, non-compressed urethra. Over here, this is a specimen of, this is a prostate specimen that's affected by BPH. We see that it's covered in these benign nodular growths, right? Encapsulated by what we call a pseudocapsule. And here we see that this growth of the prostate has resulted in compression of the urethra to a slit. We see a paperclip within this slit right here. And the compression of the urethra is what's, by the benign prostatic enlargement, is what is responsible for the symptoms that we see in benign prostatic hyperplasia, and we're going to get to that in a couple slides. Over here, this is a histological specimen of prostate that was affected by BPH. This purple tissue here is stromal tissue. That's like supporting connective tissue. And then all of these proliferations here are glandular tissue, columnar epithelial components. We see this glandular tissue that looks somewhat hyperplastic or proliferated too much, and it's sticking into the acinar lumen of all these glands. So this is an example of benign prostatic hyperplasia as it would look under a microscope. Now, this is a great picture that I lifted from, I forget if it was Rubin's Pathology or Robbins Pathology, both great textbooks. But this picture basically summarizes the current thinking of the pathomechanism that causes BPH. So in summary, if you want to really take away one thing from this slide, it is thought that BPH arises due to increased amounts and dysregulation of the response to a hormone called DHT. And DHT is a metabolite of testosterone. Now remember, the prostate is a glandular organ, and its cellular components are basically have heavy expression of androgen receptors. Remember, our androgens are things like testosterone and DHT. Those are both androgens. In this diagram, we see testosterone passing into both epithelial and stromal cells. Remember, the hormones like testosterone can kind of pass freely through cell membranes very easily. So it passes into the cells, and then it's converted by the stromal cells via 5-alpha reductase. Remember, 5-alpha reductase, it's a very important enzyme. Testosterone is converted by 5-alpha reductase into DHT, right? And DHT is what passes into, well, you can view it as passing into the nuclei, but DHT is what affects the transcription and the regulation of gene expression by the cells of the prostate. And then DHT will cause upregulated growth of the prostate tissue cells. Now, something to keep in mind is that, and this is something that hasn't been explained by clinical or laboratory science yet, during puberty, so this is think of when an adolescent male is growing up during his teenage years, we see a great spike in the levels of testosterone and DHT in the body. However, for some reason, we don't see an upregulation in prostate tissue growth. So it's thought that once men start getting older, so once they're in their 40s, 50s, and 60s, that for some reason they call them fetal growth genes, start to turn on, and this is what results in a differential response to DHT. So in older men, when there's increased DHT floating around the prostate, this is going to result in prostatic tissue proliferation, Whereas in younger men, this increased DHT doesn't really do anything, and we don't really have a clear answer to why these fetal growth genes switch on once we get older. Another thing that's implicated is increased estrogen. So over here we see estrogen, and estrogen is another sex hormone that's found naturally in everyone's bodies. Estrogen is passing into the cells, and it also regulates epithelial cell proliferation and epithelial cell death. Over here we see that estrogen tips the scale in favor of proliferation, and it also inhibits epithelial cell death and apoptosis. And this also results in a benign prostatic hyperplasia. So some of the symptoms that we see with BPH are related to compression of the urethra. This includes increased urinary frequency, urgency, nocturia, or going to the bathroom at night, and dysuria, or painful urination. It's not hard to imagine that if you're trying to urinate through a stenotic or narrowed prostatic urethra, and you can't really get the urine through, that this is a somewhat painful process, right? So it makes urination a lot less fun or cathartic. Other things include hesitancy, right? This compression results in an inability to start and stop the urine stream. Prolonged terminal dribbling, sensation of incomplete voiding, and of course urine retention. It's easy to imagine that if you're having trouble getting the urine out, this results in more urine being retained within the bladder. Another complication includes hematuria. Hematuria is a medical term for blood in the urine. And the reason why you can see this with benign prostatic hyperplasia is because with the hyperplasia of prostate cells, you also get an increase in the number of capillaries, and these new capillaries are typically a little bit more fragile. So basically, rupture and local damage to these capillaries can occasionally result in blood seeping into the urine. Because remember, the urethra passes through the prostate. On digital rectal exam, remember the prostate is right anterior to the rectum, so that if someone sticks their fingers into the patient's rectum and moves those fingers anteriorly, they can palpate the prostate. So on digital rectal exam, you will find a symmetrically enlarged, smooth, firm, non-tender prostate with a rubbery or elastic texture. Typically, if you see more asymmetry or very, very hard growths, those would be more concerning for something like prostate cancer. So complications that you get with BPH are typically related to compression of the urethra. We already talked about some of these symptoms. One of the other things that can occur is with increased urinary retention, this can result in increased reflux up through the ureters. Remember, the ureters connect the kidneys make urine, right? The ureters connect the kidneys to the bladder. So if you have increased pressure within the bladder due to poor drainage or poor urination through the prostatic urethra, this can result in more reflux and more backwards pressure into the ureters. This pressure will ultimately be seen by the kidneys and can result in dilation and obliteration of the renal pelvis. And then this is what we call hydronephrosis, which is a bad complication of BPH when it's untreated. Another thing that can happen is muscular hypertrophy of the bladder. So remember that hypertrophy is an adaptive mechanism to increased physiological stress. In this case, the man having to constantly strain while urinating, and the increased leftover urine within the bladder will cause basically a strengthening or a muscular overgrowth of the bladder, causing the bladder wall to become thicker. This is called muscular bladder hypertrophy. So let's say you're in a primary care setting or you're a medical student and you're interviewing someone that you suspect has BPH. There's a few questions in the history portion of the interview that you will want to make sure you cover. First of all, you want to ask them about their symptoms, especially the urinary symptoms. Ask the patient to describe what it's like for them to go to the bathroom. Are they frequently straining? How often are they going to the bathroom at night? Do they suffer from dribbling of urine into their pants and underwear throughout the day? Have they seen blood in their urine? These are all very important questions to ask a patient that you suspect has BPH. Also ask about drugs and medications. Certain drugs and medications, especially anticholinergic medications, can result in urinary retention, that causes symptoms that are similar to BPH. So make sure you ask a detailed history about medications, especially those that can cause urinary retention. Let me just fix this slide here. Okay. Next, you want to ask about things like hematuria, incontinence, and urine retention. These are all more alarming findings that can be associated with BPH, or in the instance of something like prostate cancer, like hematuria, can also be associated with prostate cancer. If a patient has any of these symptoms, hematuria, incontinence, and urinary retention, these are all things that would make you want to refer them to urology for further treatment and care. Also, a 3-day voiding diary can be very helpful. A lot of times patients come in with not very detailed description of their symptoms, or maybe they don't remember all of their symptoms. This is where a voiding diary, in which they basically write down every time they go to the bathroom and kind of the feelings and the difficulties that they have with going to the bathroom. They write it down into a diary, and then they bring it into their doctor to see. And then by looking at this diary, it can give you a better idea of what their symptoms are and their characteristics. Next, you want to have them do a validated questionnaire. This includes the AUA, or American Urologic Association, Symptom Index, or the IPSS, the International Prostate Symptom Score. These are both validated questionnaires that don't help as much with treatment, but rather help with tracking treatment, right? So for instance, you want to have the patient fill out these questionnaires at their first visit, and then at subsequent visits, you have them fill them out again. And then this allows you to, once you put them on treatment, it allows you to track the quantitative effect that treatment has had. So if you see their scores going down over while they're on treatment and over the course of their following up with you, this indicates that the treatment is having success. Next, you want to make sure you do a good physical exam, as you would with all patients, right? So make sure you do a good neuro exam. Lots of neurologic pathologies, including strokes and MS or multiple sclerosis, are all pathologies that can are all neurologic pathologies that can affect the urination or micturition process. So you want to make sure that you're doing a good neuro exam in order to detect any neurological pathologies that can be causing BPH symptoms. Next, you want to do an abdominal exam. Make sure you're not missing any important palpable masses or signs of infection. And then, of course, you want to do a GU exam, or genitourinary exam. This will include inspecting the penis for any abnormalities and issues, and also a digital rectal exam and palpating the prostate, as we discussed earlier, looking for symmetric, benign, rubbery, soft enlargement. So next, for workup of BPH, first you want to make sure you get a urinalysis to detect any other abnormalities, like let's say signs of urinary tract infection, prostatitis, blood in the urine, things like that. You want to get a post-void residual volume. These are really easy to get in clinic too and should be done more often. All that's required is for the patient to go to the bathroom, and then you can just use a straight catheterization method to measure the amount of urine that's left over after they urinate. Typically, in someone with BPH, you could see elevated post-void residual volumes, and typically you're not too concerned unless they have volumes like usually past 1 to 200 milliliters. In an otherwise healthy person, you will typically see values in the range of 30 to 60 milliliters. Also, you want to get a PSA if you're considering a 5-alpha reductase inhibitor. Remember, 5-alpha reductase is the enzyme that's responsible for converting testosterone into DHT. And we discussed that DHT is one of the big hormones that drives the pathogenesis of benign prostatic hyperplasia. So what a 5-alpha reductase inhibitor will do, like finasteride, is it will prevent the conversion of testosterone into DHT. And by preventing that conversion, we will decrease the effects of DHT and hopefully treat the benign prostatic hyperplasia. Now, something that you want to be careful of here is that 5-alpha reductase inhibitors are known to lower PSA. It stands for prostate-specific antigen, and it's a protease that's normally secreted by the prostate into semen. And the purpose of PSA is to actually cleave and have an action on gel-forming proteins within the semen, causing the semen to become more liquidy or to liquefy. we see elevations in PSA in both benign prostatic hyperplasia and prostate cancer, which is why PSA is considered to be a good biomarker for prostate cancer. Now you have to be careful here because we discussed that the 5-alpha reductase inhibitors will result in a decrease in levels of PSA that you see in the blood. And then this can be dangerous because let's say if later on you're trying to screen for prostate cancer, you might see an artificially low value that doesn't concern you when really you should be concerned. And this is because the 5-alpha reductase inhibitor will be lowering the PSA. So it is very useful to get a baseline level of someone's PSA before starting a 5-alpha reductase inhibitor. So now we're going to discuss some treatments. So the first line treatment, and you always want to remember this, first line treatment for BPH is going to be an alpha blocker, something like tamsulosin, which is technically an alpha-1 AD blocker, I think. So basically it acts specifically on receptors that are found in heavy concentrations within the bladder neck and within the prostatic urethra. And this is great because the alpha blocker, tamsulosin, will cause the smooth muscle within the bladder neck and the urethra to relax. And by having this muscle relax, it will hopefully open up the stenotic portion of the urethra, thus alleviating some of the symptoms of BPH. It's important to note that tamsulosin won't really affect the underlying pathogenesis of BPH, but rather it will really just alleviate some of the symptoms. Another thing that's great is a 5-alpha reductase inhibitor. So this would include something like finasteride, which would decrease the levels of DHT, which drive the pathogenesis of BPH. And typically, if those two medications don't work or you need further management after that, at that point you would need referral to a urologist. There's also other medications that can be used, though these medications are much less common. So these include antimuscarinics and phosphodiesterase inhibitors. Can be useful in certain patients, but again, not as common. So other treatment for BPH that's not pharmacological will include surgery, and these are typically all done by a urologist. So TURP, or transurethral resection of the prostate, is considered the gold standard surgery. This is a great surgery in which quite literally components of the prostatic urethra are shaved away by a device, thus opening the stenotic portion of the urethra and alleviating the patient's symptoms. Another possible treatment is prostatectomy, which is surgical removal of the prostate, though this is rarely done for treatment of BPH and is only done in very special cases, like let's say the patient also has prostate cancer at the same time, or their prostate is absolutely enormous, like 80 grams or something like that. Other treatments include laser enucleation, thermotherapy, and prostatic urethral lifts, all very interesting procedures that can be done by urologists and other healthcare professionals in order to treat BPH. And with that said, I believe that's all my slides, so thanks for watching.